Welcome to The Explainer. So today, we're actually cracking open a pretty fascinating medical mystery. Imagine a patient rushing into the ER with severe, absolutely life-threatening liver complications. We're talking things like variceal bleeding or massive abdominal swelling. Naturally, every clinical instinct screams that the culprit here is advanced cirrhosis, right? But when the lab results and the biopsies come back, the usual suspect is completely missing. The liver isn't cirrhotic at all. So, what exactly is happening in the shadows of the vascular system?
Okay, let's dive into this. We're essentially looking at a fundamental plumbing problem. Think of the liver as this massive, highly intricate filtration plant. Now, in a normal cirrhotic patient, you get this thick scar tissue that strangles the pipes, causing pressure to build up dangerously. We know that as portal hypertension. But today we're looking at a wild anomaly. The dangerous pressure spikes, those pipes swell right to the bursting point. But the liver tissue itself, it's surprisingly healthy and totally free of that cirrhotic scarring.
And because this condition so perfectly mimics the end-stage complications of a failing liver, it is an absolute master of disguise. Get this, when patients with this specific type of portal hypertension show up at the hospital, they're misdiagnosed with cirrhosis in a staggering 70 to 80% of cases. I mean, wow, that's not just a minor slip-up, that's a massive clinical blind spot that drastically alters how a patient is treated and understood.
So, here is our roadmap for today's explainer. We'll start with the cirrhosis imposter, then move to defining a new disease, the root causes, under the microscope, the diagnostic puzzle, and we'll wrap up with treatment and management. Let's get into it.
Section 1. The cirrhosis imposter, a master of disguise. You know, when a patient rolls in with variceal bleeding, which is when those swollen veins in the esophagus actually rupture, it's an absolute emergency. The clinical picture looks identical to end-stage liver disease.
But here is where the imposter's mask actually slips. If you compare this condition directly against cirrhosis, you're going to spot a glaring difference. In cirrhosis, the liver's ability to produce essential proteins and clear out toxins, its synthetic function, tanks pretty early on. But in this imposter condition, the liver's synthetic function remarkably stays completely normal until the very, very late stages of the disease. The patient is suffering from extreme vascular pressure, sure, but the liver tissue itself is just quietly humming along, doing its job.
Moving on to Section 2. Defining a new disease. Unifying the terminology. For over a century, this disease has been incredibly confusing to pin down, and getting a unified definition finally brought it out of the shadows.
Historically, this was, well, a really messy space. Back in the 19th century, a physician named Banche noticed this phenomenon and called it splenic anemia because he figured the spleen was to blame. Jump to the 1960s, and Michelson introduced the term hepatoportal sclerosis to describe the hardened microscopic veins. And over the decades, we basically ended up with this alphabet soup of names: non-cirrhotic portal fibrosis, idiopathic portal hypertension. It was a lot. It wasn't until 2019 that the Vascular Liver Diseases group finally cleaned this whole thing up and created one single unifying term.
And that term? Portosinusoidal vascular disease, or PSVD. The definition is elegant and precise. It's a group of liver conditions causing portal hypertension in the absence of cirrhosis or portal vein thrombosis. By grouping all of this under the PSVD banner, researchers and clinicians can finally track, study, and treat this condition without getting bogged down by a dozen overlapping historical names.
Section 3. The root causes. Why does this happen? Seriously, what is the motive here? Let's investigate why this microscopic plumbing actually fails.
What's really wild is just how incredibly diverse the triggers for PSVD are. It's definitely not just one thing. It can be driven by hypercoagulability, where the blood clots way too easily due to protein deficiencies. It's also heavily linked to autoimmune conditions, think lupus or rheumatoid arthritis. Genetics play a massive role too, with links to things like cystic fibrosis and telomere gene mutations. And critically, it can be triggered by drugs and toxins. We're talking chemotherapy agents like oxaliplatin and older HIV meds like didanosine. Essentially, chronic inflammation, tiny blood clots, or toxic exposure damages the microscopic pipes inside the liver over time, which means anyone undergoing these really common treatments could actually be at risk.
And this brilliantly illustrates exactly where PSVD sits in the broader landscape of vascular issues. When we look at non-cirrhotic portal hypertension, the blockage can be prehepatic, meaning before the liver, like a major blood clot, or it can be posthepatic, which is usually due to heart failure pushing the pressure backwards. But PSVD? It's entirely intrahepatic. The damage is happening at the microscopic cellular level, right inside the liver's intricate vascular web.
Section 4. Looking under the microscope. The crime lab. To really see that damage, we need to look closely at the physical evidence PSVD leaves behind.
Down in the crime lab, so to speak, pathologists are basically looking for two major smoking guns under the microscope. First up is obliterative portal venopathy. This is where those tiny portal veins become thickened with fibrous tissue, or sometimes they're entirely obliterated, just missing altogether. The second clue is nodular regenerative hyperplasia. Because the blood flow is so restricted, parts of the liver literally atrophy, while other parts hyper-regenerate to compensate. This creates these very distinct, tiny nodules, but without the thick fibrotic scarring you'd typically see in cirrhosis.
And all that microscopic damage? It creates some serious macroscopic chaos, which is crystal clear on an MRI. Because the blood just can't flow smoothly through the liver's microscopic sieves, it backs up. The result is massive splenomegaly. The spleen becomes enormously enlarged from that backlog of blood. You also get these massive portosystemic collaterals. The body is literally trying to build new, swollen bypass pipes to route the blood around the liver, desperately trying to relieve that intense pressure. Which brings us to Section 5, solving the diagnostic puzzle, catching the culprit. So how do we definitively catch this thing and tell it apart from a cirrhotic imposter? Well, the clinical flow usually starts with unexplained lab abnormalities, maybe a low platelet count or spotting varices on a routine endoscopy. From there, we use non-invasive elastography to measure liver stiffness. Now, in cirrhosis, that liver stiffness number is sky-high, but in PSVD, it's often surprisingly low, frequently under 10 kilopascals. But here's the catch. Because non-invasive tests aren't foolproof, the absolute gold standard for catching PSVD is an invasive liver biopsy, and it has to be a robust one. The specimen needs to be at least 20 millimeters long to ensure the pathologist actually has enough portal tracts to find those incredibly subtle microscopic clues we just talked about. Let's move to and see how this builds into a really comprehensive diagnostic algorithm. If a patient has unexplained liver enzyme abnormalities, or maybe they have a known autoimmune condition or a history of certain chemotherapies, we kick off the workup. If their liver stiffness comes back relatively low, but they still have clear signs of portal hypertension, like those varices or an enlarged spleen, that triggers the biopsy. The biopsy is key because it rules out cirrhosis. If we then find those specific histological features we mentioned, or even non-specific features combined with high portal pressure, boom, we have our definitive PSVD diagnosis. Section 6, Treatment and Management, Fixing the Plumbing. All right, once we finally have our diagnosis, how on earth do we manage this unique condition? Here is the absolute crucial takeaway. Treat the pressure, not the liver tissue. Remember, in PSVD, the liver is actually maintaining its synthetic function just fine. It's producing proteins, it's filtering. The immediate mortal danger to the patient isn't liver failure, it's the plumbing. It's the sheer risk of those swollen varices bursting and causing a catastrophic bleed. Because of that, our whole game plan is focused on cardiovascular and endoscopic interventions. We use non-selective beta blockers, things like carvedilol or propranolol, to actually lower the cardiac output and dial down the pressure in the splanchnic veins. Those are the blood vessels supplying your abdominal organs. If those varices are large and look like they might burst, gastroenterologists will go in and perform endoscopic variceal ligation. Basically, they're putting tiny rubber bands on the swollen pipes to prevent them from rupturing. And in really severe cases, where meds and banding just aren't cutting it, we construct physical bypasses, either surgically or through a TIPS procedure, to physically vent all that pressure away from the liver. Which brings us to a final, highly provocative thought. For decades, PSVD was considered incredibly rare. But think back to its root causes for a second. Chemotherapy medications, HIV medications, autoimmune diseases, immunodeficiencies. Thanks to modern medicine, patients with these previously fatal conditions are now living much, much longer. But that prolonged survival gives the microvascular damage inside their livers decades to accumulate. As we get better at keeping patients alive through cancer and complex immune challenges, PSVD might just step out of the shadows and become one of hepatology's next great challenges. It's really a testament to how solving one medical hurdle often reveals the next one hiding right behind it. Thanks for joining me on this explainer, and I will catch you on the next deep dive.